for therapy services, this is physical therapy, occupational therapy, and speech therapy. You need same discipline supervision. So the physical therapist supervises the physical therapy assistant, the occupational therapist supervises the occupational therapy assistant, and the speech therapist or speech language pathologist supervises the speech therapy assistant. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we're going to be talking about supervision policies within the home health and hospice industry. But first, if you like our content, please like, share, and subscribe. What is clinical supervision? Clinical supervision is done for a variety of reasons that include general oversight and guidance. So this is like we're making sure that the care is being done appropriately. Then there's compliance and quality assurance. This makes sure that the care that is being delivered is according to your laws, the laws and regulations of the state, federal, any kind of accrediting organization, and to the policies of your company. This is different maybe from the oversight and guidance in that something might be appropriate clinically, but not according to your policy, like not checking every piece of your policy. Then there's training and mentorship. So pretty much maybe you have somebody new or somebody that's not as experienced in that specific, thing that they're doing. Maybe you've done a competency and they're fine, but you still want to kind of keep an eye on it. It's a complicated case. So in that sense, like there's supervision that happens to make sure that everything goes okay. And if anything pops up that's unexpected, that you can address it together. Then there's patient safety and risk management. So along with that kind of in concept, you want to make sure that things are being done appropriately in the patient care concept and also according to the care plan. And lastly, it's for documentation and evaluation purposes. For example, supervision in the case of checking documentation and making sure that the documentation is done according to appropriate standards and that it also covers everything that's been done in the actual visit. Because as we know in healthcare, if it wasn't documented, it wasn't done. So let's talk about different ways that supervision can happen in home health and hospice. First, there's the really obvious one, and that's in-person supervision. A clinician goes to the place the service is being provided and, evaluates and things like that, just like kind of looks to see what happens. In-person supervision doesn't mean that the person being supervised is there. So that's its own category. In-person supervision just means that the supervising clinician goes to the patient's home and for example, in the case of home safety evaluation, right? Like you might have something in the charts about home safety and this and that, like there's no boxes on the floor, there's no wires everywhere, slip rugs, and then you go and there are those things. So there's benefit to having in-person supervision, even if that clinician is not on site, the one that's being supervised. You can ask the patient questions and the caregivers and so on. The next one is a virtual or phone check-in. An example of this is like looking over the chart, maybe having a case conference, and then calling the patient to both confirm the information and also kind of get their perspective or their feedback on like the quality of care. Are they happy with services and things like that? Another form of supervision is chart review. So maybe you're reading the chart to make sure that whatever was done is documented, whatever is documented is done, and also that all of this is according to the care plan and to the agency's policies and procedures. And lastly, you have joint visits. This is when the visit is being conducted and there is another supervising clinician watching the visit being conducted and making sure that everything is going according to policy, procedure, care plan, state, and federal regulations, accrediting organizations, and so on. Like when I think of supervision, I only consider the joint visit concept. I always think, it's like two clinicians coming. One of them is like watching the other one perform the work. But there are actually, as we've just covered, other ways to do this. There's also, in the case of therapy, other concepts of supervision. Like, for example, when you have therapists and assistant therapists, at that point, usually the evaluating therapist is co-signing the assistant's visits. There's things like that where the co-signature indicates a chart review, right? Like they've read the note, the note is according to their standards and they co-sign for the note. So there's a lot of different ways of supervision, and it's important to know when each one is appropriate and according to the regulations of whatever organization, and also appropriate to the patient care. And so we're about to jump into the specifics of per discipline supervision requirements for both home health and hospice. But it's important to remember that in a lot of cases, there aren't really specific rules around it, because supervision outside of the parameters of the requirements, meaning the requirements are the minimum requirements, right? So like you might have clinical cases that are more complex and you might want to have a little more supervision on this. You might have clinicians that are newer to the industry and you might want to have more supervision on the clinician. So we are going to be talking about the minimum requirements based on federal guidelines and Medicare guidelines. In home health and hospice, actually, the concept of supervision goes for evaluating level staff to assistant level staff. And so in this scenario, in home health specifically, RNs supervise LVNs every 30 to 60 days. So let's talk about home health specific supervision policy. First and foremost, a lot of times supervision isn't clearly outlined in the regulations to account for personalized and like custom, supervision frequencies based on various scenarios. Typically, RNs will supervise LVNs every 30 to 60 days. This is done anyways because you're recerting or discharging at 60 days anyways, right? Like, it's not like you can go past an episode without an RN going and doing an evaluation. When they are at the evaluation, they can then do the in-person supervision with the LVN being off-site. And so a lot of times if you're using Briggs Oasis forms, or a lot of softwares will have this already in their Oasis forms, you could just document right into the Oasis your supervision and you have met the requirement. In every instance of supervision, except for home health aides, you're going to have same discipline supervision. So like a physical therapist can't supervise an LVN. An RN has to supervise the LVN. For therapy services, this is physical therapy, occupational therapy, and speech therapy. You need same discipline supervision. So the physical therapist supervises the physical therapy assistant, the occupational therapist supervises the occupational therapy assistant, and the speech therapist or speech language pathologist supervises the speech therapy assistant. The laws around therapy generally require a reevaluation every 30 days. This reevaluation also can count as supervision if supervisory elements are in there. But the point of the reevaluation for therapy, if you have an assistant on the case, is to evaluate the assistant's progress and the patient's progress towards goals, which is like directly tied to the assistant's work, right? So like if the assistant's not doing their job, the patient's probably not progressing towards the established goals, which are achieved through the various exercises that are prescribed. And so kind of naturally, the therapy assessments happen. Supervisions happen every 30 days anyways during the reassessments. Just make sure that you're hitting those specific supervisory points. For social workers, there's not really like any rules around social work supervision, but that's also because social work typically isn't a discipline that happens like weekly, in this way. Usually within a home health episode, unless there's like just dire abuse issues and just things like that, the social worker is in and out once, maybe. Like, even not all patients get social worker, and when they do, it's like 1 visit, 2 visits max. In the case of a diabetic patient, they might be just like evaluating needs and if there's an appropriate caregiver. So like, you just don't have the opportunity for social work supervision because like usually there's not enough visits in the frequency to have like an evaluation level staff, an assistant, and then again evaluation level staff. Like, you're maxing out at 2 to 3 visits normally with social work, if that. In terms of kind of who supervises who with social work, you're going to have the master's level social worker supervise the bachelor's level social worker. So That's how it goes. The only discipline where it's not the same discipline supervising is the home health aide. That's because they don't have an evaluation level discipline kind of person. The home health aide is a standalone discipline with a standalone like staff member within it. But because they are providing like non-skilled care for the most part, the supervision has to happen very often. And the COPs around this are very strict and they're always checked at surveys. So you really want to be careful with this. Supervision needs to happen at least every 14 days. If you're on the 15th day, you're out of compliance with the COPs. Typically, the RN will supervise the home health aide. However, if there isn't an RN on the case, like let's say it's a PT only case, right? Then the physical therapist can supervise the home health aide. However, if there is an RN, like if there is skilled nursing service, then the RN must supervise the home health aide. And lastly, let's discuss hospice supervision policy requirements. For hospice, the first kind of idea you want to keep in mind is that the registered nurse is going to be the general case manager for the entire hospice care. And of course, the hospice doctor, right? In the hospice program, there's separate from like the supervision concepts, there's a requirement that the hospice RN visits the patient at least every 14 days to assess like, kind of progress and patient status and just like assess changing needs. Because hospice patients typically needs change sometimes faster than home health or under other industries. And so you have an RN there every other week, pretty much. Once the RN does the assessment every 14 days, then the IDG group meets and kind of talks about it. And all of the representatives, from the various disciplines, the required disciplines are present and they are discussing the case. This like requirement, hospice 101, like that. And this happens at least every 15 days. That process can be supervisory if supervision is documented and discussed. As long as you are remembering kind of the types of supervision you can have and the elements and how to, like for example, chart review is a way of supervising. And so in the IDG, you're reviewing the RN's assessment, you're looking at the different notes that have come in, and the various representatives of the IDG group are discussing the case. So this is a case conference. This is also supervision. And so the RN oversees all patient care and supervises the LVNs or LPNs. In hospice, even though the RN is kind of the case manager of the hospice team, you still have supervision within the disciplines. And so if you have therapy, there's no real like rule about therapy supervision in hospice care, but like a PT supervises the PT assistant, the OT supervises the OT assistant, and the ST supervises the ST assistant. For social workers, again, no real rules about frequency of supervision, but again, a master's level social worker will supervise the bachelor's level social worker. The main supervision as always comes with the home health aide, or in this case, the hospice aide. I think the official term is home health aide, but then sometimes we call it hospice aide, whatever, the aide. The RN is conducting that supervisory on site at least every 14 days when they're doing their RN assessment anyways. This becomes kind of like part of the process with this required RN assessment every 14 days on site anyways. There is a requirement of direct observation of aid care at least once a year, but that's also covered through your competency. As long as the competency is done on a patient, which is also kind of the rule, then you are fulfilling that requirement as long as you're also like supervising for those elements. So for example, what do I mean by that? When you're conducting a competency, you are specifically checking for the clinical skills. With supervision, there's like soft skills you're also looking for. For example, a big COP is, does the aide or other clinician honor patients' rights? So typically that's not going to be part of a competency, but it is part of a supervision. So as long as you are documenting those supervisory elements and of course supervising for them, then you're in compliance. It's cool in the sense that a lot of these requirements double up with other requirements. So you can, as long as you're aware that you need to be doing this and you make it a habit and you make sure you do it, you're already checking that box anyways. Of course, if the evaluating clinician finds any issues, now we're talking about something else. Now we have to verify the skill again and all this stuff. But just like in terms of regular supervision frequency, for a lot of these disciplines, there's no real definition for the frequency of supervision. And that's again because of, you want to account for specific patient conditions, the skill and experience level of the clinician. There's a lot of variables. And I think if we do start setting these like parameters, people will use them as, okay, I need to hit this box, versus this patient needs this or this clinician needs this. That's why it's done like this. And also we're probably not like in the habit of just like making rules for fun. So unless the need arises, they're not going to make additional supervision requirements. But we've mentioned competency, and for both home health and hospice, and of course other healthcare industries, we're just not involved in that. You do have a requirement for annual competency, so annual skills evaluation. That's not the same as supervision, and sometimes people ask, like, what's the difference, right? And the difference is this: the competency checks for your ability to perform the service, whereas the supervision checks if you have performed the service properly. You can know how to do something and do it wrong because like you don't care, or you miss a step or whatever. And so that's kind of the difference between the competency and the supervision. The competency kind of looks forward to see if are you capable of doing this stuff, and the supervision looks backwards. How did you do it? So that's kind of like the ideological difference. So for the most part, that's pretty much it for home health and hospice supervision. There are like other chart review elements. There are other times that also double up for supervision. Like you might be doing 30-day case conferences. That could be an opportunity for supervision. There's just like a lot of opportunities for supervision. As long as you know the kinds of supervision you could do, you could intentionally incorporate them into other activities that you're already doing that are requirements. That's the rules around supervision in home health and hospice. Of course, I'd like you guys to all remember that these are the federal requirements, meaning the CMS requirements. Like there might be state-specific additional requirements. That's, whatever state you're in, please look those up. But this is what CMS looks for and what your accrediting organization is going to look for in your survey, unless there are other state-specific additional rules and accreditor-specific additional rules. But if with the COPs, you're good with this stuff. So that's it for home health and hospice supervision policies. My name is Mariam Treystman from the Home Health Consultant. And if you enjoy this content, please like, share, and subscribe. Thank you.